office bearers who have given me this opportunity to talk to you on this topic of role of OCT and HYBIZ in optimization of PCI. This topic is volumes and chapters. I have to condense it in 9 minutes. It's impossible. But anyway, nevertheless, I'll try to do my best. And I take it this investigative tool as a third empire. When your clinical picture is not very certain, it's ambiguous, your angiogram is borderline or indeterminate lesion, probably OCT or HYBIZ will be the third empire to decide whether you are in or out with your stent. So lots of times we use the angiography as the gold standard earlier years, but now we have the quantitative angiography, we have the OCT and HYBIZ which is there, and we have the FFR for physiological assessment of the lesion if it's an intermediate lesion. Nevertheless, the most important point is we have the CT FFR also coming in now as a diagnostic modality to pick up patients with coronary artery disease who have obstructive CAD, which is hemodynamically significant. On your left, you'll see the percentage diameter stenosis and the various ways you are measuring your inducible ischemia with the non-invasive methods like myocardial perfusion imaging. You have the stress test, you have the dobutamine stress echo, and on your right you have the hyperemia indices and the resting flow indices on the right side, on the lower side there. The entire gamut of information from physiology and imaging is important for us to appropriately assess the need for an intervention. More or less, we depend on the diameter stenosis often, and definitely this is one imaging modality. The HYBIZ and the OCT are very important imaging modalities for us to make a clinical decision to decide when to intervene, how to intervene, and what is the best way of giving the intervention for this group of patients. High resolution imaging is here available today, and the resolution of OCT and HYBIZ is quite high, especially the OCT has 10 micron definition there. The resolution is quite good, and we have very good clear pictures there. We have today a hybrid OCT HYBIZ available coming into the market now, and probably it will be launched very soon in a year or two, where you have both the OCT sensor as well as the HYBIZ transducer at the tip of the catheter to give us both a high resolution picture and a low resolution deep imaging pictures for this. And what do we do? Why do we need this HYBIZ and OCT? Is to optimize the stent results. The most important step is that we do a pre-intervention HYBIZ or OCT to decide on the vessel size, the reference segment, the calcification, the bifurcation, and also do a post-intervention HYBIZ and OCT to look at the apposition, expansion, residual plaque, edge dissection, and so on and so forth. So it's important that we do a pre-intervention as well as a post-intervention pictures, and then the benefits of intracoronary imaging with PCI are very, very clear in patients who have extensive calcification, to know what is the arc of calcium, the depth of calcium, the length of the calcium there. Look at the character of the lesion. Are there any vulnerable plaques? Is there a thin cap fibroathyroma? Is there an erosion which does not need much treatment, probably medical management? A ruptured plaque would definitely need a stent. A dissection, a plaque prolapse, a protrusion, red thrombus or white thrombus can be differentiated on OCT very clearly. The red thrombus absorbs and reduces the backscatter there. Acute stent malapposition, limited impact on the clinical practice, but nevertheless there has been a slightly higher incidence of stent thrombosis in this group of patients. Late stent malapposition for instant restenosis. Optimal stent length and dimension assessment is very, very important. Safe landing zones are equally important when you get a good imaging with OCT or HYBIZ. Stent stud coverage during the healing process. The instant restenosis plaque assessment can be done. Proximal and distal dissections can be assessed to the need for additional stents. Post-stenting optimization with the high pressure inflation sometimes to get the maximum luminal area there. And definitely these optimization techniques lead to a reduction in restenosis and stent thrombosis there. What makes the plaque vulnerable is well known to us. It's a minimum luminal area of less than 4, high plaque burden, low attenuating plaque, lipid-rich core, positive remodeling, thin cap fibroathyroma. These are the various features which make a plaque vulnerable, and almost all of these features can be assessed by our OCT as well as the intravascular ultrasound. Probably OCT scoring a little bit more on over the HYBIZ there. This was one of the landmark trials by Zayed Ali group, a randomized trial comparing an OCT-guided PCI versus an IVUS-guided PCI versus an angiography-guided PCI, and the Lumen 3 used the EEL-guided lumen measurement to decide on the stent sizing there, and this is the assessment of the lumen. The earlier trials used the lumen as the way to measure the stent dimensions. Later on it was mid-wall, and now it is the external elastic lamina, wherein you assess the EEL to EEL dimensions and take the stent size. IVUS definitely has seen to be oversizing the stent sizing when compared to OCT, but nevertheless, when you use IVUS, probably you undersize by about 1/4 millimeter, and when we use an OCT, we oversize by about 1/4 millimeter. So the various algorithms available for OCT stent optimization, the safe landing zone, the proximal MSA, the proximal reference segment, it should not be less than, the optimal would be more than 90%, but definitely it should not be less than 80% there. The various ways of as I'm doing the IVUS and OCT, they found that the final post-PCI MSA by OCT was slightly smaller than the IVUS, but nevertheless OCT was not inferior to the IVUS. But definitely the dissection detection was better. The malopposition detection was much better with OCT, both major and minor, as well as the plaque thrombus protrusion detection again with was better with the OCT versus the IVUS arm. So it has an advantage. Nevertheless, OCT was found to be non-inferior to IVUS in regards to minimum stent area. It was more dissections and malopposition and plaque protrusion and thrombus were detected. Doctor's trial was one important trial wherein they found that high rate of stent under expansion malposition was detected when they used OCT and IVUS, OCT versus angio, and almost 32% of the patients had a malposition and about 40% of the patients had an under expansion, needing additional stent deployment techniques to optimize the results there. So one of the cases where stent malposition and the longitudinal view showing that there is a red there and the telling us that there's a significant malposition of the stent, and you have an extremely good longitudinal view as well as the cross-sectional view showing an underexpansion of the stent, one of the very important markers for a stent thrombosis as well as an in-stent restenosis developing in this group of patients. So this is a very good tool. Underexpansion predicts DS stent thrombosis. Various studies have shown this. And one of the most important thing is underexpansion and a small MSA being responsible for an early thrombosis as well as a stent restenosis. A vast amount of studies are available which clearly give us the guideline that underexpansion is very important for in-stent restenosis. This is the CLI OPCI study from Italy, which has very clearly shown that the death and myocardial event rate is definitely much less with an OCT-guided procedure when compared to a angiographically guided procedure. What has OCT shown? That when you have an MLA of less than 4.5 or 4, the distal reference narrowing is there, and you have a significant plaque burden, distal edge dissection is there, or proximal reference narrowing is there. These are the important factors which have decided that these patients would have a higher MACE when you do a OCT when compared with a angio-guided procedure there. Calcium scoring systems are very well defined with OCT when compared to the IVUS. The calcium thickness, the length of the calcium in the vessel wall, as well as the calcified, the arc of calcium decides the way to go ahead. Is it with atherectomy, scoring balloon, rotablation, and whatnot. So you have a lot of advantages of this. Most often I would recommend a left main stenting almost always should be done with an IVUS or an IVUS. OCT at the large vessel has limited advantage. And high definition IVUS is now coming, and it's giving as good pictures as the OCT. I'm probably not matching the OCT for the dissection and the protrusion, plaque protrusion, thrombus assessment. Another trial which has very clearly shown that the smaller final lumen area, tissue protrusion, edge dissection, and residual stenosis decide on the way. One of the important advantages of using the OCT or imaging ultrasound guidance is that your duration of DAPT can be shortened when you have an excellent deployment of the stent. This is ADAPT-DES study, which is very clearly shown that angiographic guidance gives a higher MACE when compared to a HYBIZ-guided PCI, and the duration of the DAPT can be definitely reduced in this group of patients. Here is a patient who has, I'll just take another 30 seconds, and a very ambiguous lesion there, not very clear. We thought probably it should be for medical management, quite atypical chest pain, no ECG changes, troponin negative. And we went ahead and did an OCT for this particular individual, and we find that there was a significant thrombus in the lumen. There was a plaque rupture. There was a, if you look at the various, there's a red thrombus there. There's a plaque rupture. There is a recanalized multiple small lumens there, and there was a false lumen, a true lumen there, a significant plaque rupture. This vessel had to be stented, and we had an extremely good result. So plaque morphology can be really assessed in a beautiful way with this technology, and the results of the stenting can be properly assessed. Thank you for your patient hearing.